Okay, let's go ahead and get started. Welcome everyone to Medicine Grand Rounds. Today we have Dr. Jessica Kendrick uh, presenting on a really important topic, which is racial disparities in chronic kidney disease. Dr. Kendrick is a professor of medicine in our division of renal diseases and hypertension here at the University of Colorado. Dr. Kendrick received her undergraduate degree from New Mexico State University and her medical degree from the University of Texas at Galveston. We were fortunate to recruit her here after medical school as a house staff in our residency program. She stayed for her fellowship program here, and we were fortunate to keep her on as faculty following the fellowship program. She also completed a master's in public health from the Colorado School of Public Health here on our Anschutz campus. Jessica has had a really interesting focus in her career because although she's been involved in clinical trials, she has focused these clinical trials on translational questions in chronic kidney disease. And she specifically focused on vitamin D and metabolic and therapeutic consequences of vitamin D supplementation, as well as sodium bicarbonate in individuals with chronic kidney disease. And she's not only focused on the kidney and its response, but also cognitive responses in terms of these therapeutic interventions. Really, really important, impactful studies that have been funded by the NIH because of their importance and because of their biological grounding. So it's a pleasure to introduce Dr. Kendrick to you, and I really look forward to her talk today. Before she gets started, and my apologies, Jessica, before she gets started, please submit your questions to the Q&A box, and we'll be watching them throughout the presentation, and then I'll have a conversation with Jessica at the end of the presentation.
Okay, I'll go ahead and get started. Thank you very much for that introduction. It's really an honor to be here today to talk about a topic that I'm very passionate about, and that's disparities in chronic kidney disease. And today I'm going to be focusing on racial disparities in chronic kidney disease. And so my goal is really to bring awareness of these disparities that exist, kind of talk about the factors that promote them, and then finally look at ways that we as healthcare providers can address these issues in disparities. I don't have anything to disclose. And here's the learning objectives, which I just went over. So I do want to start with a quote from Dr. Martin Luther King Jr. Of all the forms of inequality, injustice in health is the most shocking and inhumane. And then we're going to look at a case. So this is a 60-year-old Black male with a history of hypertension presenting to his PCP's office to establish care. He last saw a physician about 3 years ago at an urgent care when he was seen for a foot injury. 5 years prior to that, he was told by a primary care physician that he had hypertension. And he was started on a medication, and at a follow-up visit, his blood pressure was normal, and he's currently not taking any medications. He was recently able to obtain health insurance, which is why he's now presenting to establish care. His mother also had hypertension, and his father had diabetes. He doesn't smoke or drink. On exam, he's hypertensive, mildly obese. He has some lower extremity edema, but his exam is otherwise unremarkable. So when you get his labs back, you see he has a creatinine of 3.2, which gives him a GFR of 24. So this is stage 4 chronic kidney disease. We can also see that he's got some metabolic acidosis as his bicarbonate's low. He has some proteinuria and his hemoglobin is low. So this is unfortunately consistent with advanced chronic kidney disease, stage 4. So I do have a couple polling questions for you in the audience. So compared to a white man of the same age with the same comorbidities, this patient's risk of progressing to end-stage renal disease is lower, the same, or higher. So I'll give you some time to answer this quick poll. Good. So we'll kind of go over why this is, why this patient has a much higher risk of progressing to end-stage kidney disease. So another question for you. Compared to a white man of the same age with the same comorbidities and insurance, this patient's chances of getting a kidney transplant are lower, the same, or higher. And this is correct as well. So his chances are lower, and we'll talk about this and why this disparity also exists. So before I go through this, I just want to go over what the definition of a health disparity is. So the difference in health status among groups is what's known as a health disparity. They exist across all health areas, and they're present at the national, state, and local levels. And the causes are very complex, and this is what you'll see throughout this talk. And unfortunately, end-stage kidney disease is one of the most dramatic examples of a health disparity. And in fact, when I was getting my master's in public health, every time they had an example of a healthcare disparity, chronic kidney disease was the example that they gave. And I'll show you the reason why in just a minute. But before I do that, I'm going to be focusing on racial disparities today. And so an important point I want to bring up is that race is a social, not a biological construct. And so what I mean by that is there's more variation within a race than between races at the level of our DNA. So races are not real in a biological sense. This doesn't mean that race is imaginary, right? Our perception of race has real consequences on the health of others. And unfortunately, different racial and ethnic groups are treated differently. And so I just want everyone to kind of look at that lens of race being a social, not a true biological construct. So why do I say end-stage kidney disease is a very dramatic example of a health disparity? Well, when we look at racial ethnic minorities, they have a much higher incidence and prevalence of end-stage kidney disease. So here I'm showing you the incident rate of ESRD per million population, and you can see it's dramatically highest in the Pacific Islanders and Native Hawaiians, followed by Blacks and then Hispanics. And if we look at the incident rate over the last pretty much 18 years, we can see this difference as well, that it persists. So this top line are the Blacks, and this bottom line are the whites. So whites have pretty much remained stable. Good news is there's been some decline in the incident rate for Blacks, but still a huge difference between whites in the incident of end-stage kidney disease. If we look across ethnicity, we see something very similar. Here's non-Hispanics on the bottom line and Hispanics on the top. Again, there's been some decline over the last 18 years, but there maintains a big difference in the incident rate between Hispanics and non-Hispanics. So it was thought, well, if they have this higher incidence of end-stage kidney disease, they must have a higher prevalence and incidence of earlier stages CKD. But in fact, this is not true. So if we look over here on the left, we can see if we look at early CKD. So this is stages 1 to 3, so meaning the GFR is not below 30. And if we look, we can see that Blacks compared to whites have pretty much the same prevalence, and Hispanics have a slightly lower prevalence. But then if we look over here on the right side, we can see what happens once they reach end-stage kidney disease. So Blacks have almost a 4-fold increased prevalence of end-stage kidney disease compared to whites, and Hispanics a 45% increase. So there's something here that despite the lower prevalence, these patients are more likely to progress to end-stage kidney disease. And in fact, they're both more likely to progress than whites to end-stage kidney disease. Here I'm showing you data for Blacks. And for any given GFR, you can see that they're at a much higher risk for progressing to needing dialysis. So even if we look at these patients here with a GFR greater than 60, so this isn't even stage 3 kidney disease, they still have a 2-fold increased risk if they're Black of progressing to end-stage kidney disease compared to whites. And even those with the GFR less than 15. And remember, most patients need dialysis when the GFR is less than 15 or less than 10. But if you're Black, you have a 41% increased risk of progressing to needing dialysis compared to whites. And again, this is for adjusting for age, sex, diabetes, hypertension, and other risk factors that have been shown to be associated with the progression of kidney disease. And another interesting thing that we see is there is a reversal of the Black-white mortality rate in the general population. So here on the left, I'm showing you just the mortality rate in the general population. This is from 2018. But what you can see here is Blacks have a higher mortality rate than whites. But look what happens on the right. This is when these patients get onto dialysis, there's a reversal. Whites now have a higher mortality rate than Blacks. This has been looked at, it's been hypothesized for the reason many believe, at least the hypothesis is that, Blacks are often younger when they start dialysis, so they have less comorbidities, and this may be what their survival advantage is. But as you can see, what I've shown you so far is end-stage kidney disease is primarily affecting our minority patients. And if we look at it, and sometimes we need to show people the money, right? You got to follow the money in some of these things to show them the costs. We know end-stage kidney disease is incredibly expensive. It costs over $41 billion a year. If we could lower the incident rates of our minority groups to that of the whites, we could get rid of an excess of $13 billion in costs just by trying to bring them back down to sort of this level playing field. So again, showing how costly these disparities are in addition to the morbidity and mortality associated with them. So let's move on and look at some factors that contribute to these racial ethnic disparities. And again, as I mentioned earlier, they are very complex and it's not going to just be one factor. So we know in the case of minorities, there's excess prevalence of key risk factors for chronic kidney disease, including higher rates of diabetes, hypertension, and glomerulonephritis. There also can be dietary and lifestyle factors, as well as socioeconomic factors. So if we look at just the incident rate of diabetic end-stage kidney disease, meaning the cause of the end-stage kidney disease is diabetes by race and ethnicity, you can see it's much higher in Blacks, American Indians, Alaska Natives, and Hispanics compared to whites. We can also see a big disparity in hypertension. This data is actually looking at the general population. So this is using data from the National Health and Nutrition Examination Survey. And what you can see here is Blacks have a higher prevalence of hypertension, whereas whites and Hispanics, pretty similar. However, where we start to even see bigger differences is in blood pressure control. So on this far left is pretty much what I just showed you before. Whites are in blue, orange is Blacks, and Hispanics are in the gray. And what you can see is just in general for hypertension, any stage, for higher prevalence in Blacks, whereas Hispanics and whites are pretty similar. If we look at treatment eligible, which means in this particular study, when they had stage 2 hypertension, again, more of the Blacks fell into there, Hispanics and whites pretty similar. If we look over here on the far right, once these patients got onto treatments, these were ones that were treated with antihypertensive agents. Here's where we see a big disparity. These are the patients who were not at goal. So unmet goals, meaning blood pressure is not there. You can see it's almost 64% of Blacks, 58% of Hispanics, compared to 49.7% of whites. And these are all the other races here in the 60%. So there's a disparity in blood pressure control. Now, we're not doing great across the board anyways. We'd love to have, 75, 80% of all patients there. But again, big disparity in how blood pressure is even being controlled. A few years ago, our group surveyed all of the PCPs here at the University of Colorado and Denver Health. And we wanted to look to see what their beliefs were about racial ethnic differences in the quality of hypertension care. And these are just one example of our findings. And so these were, we asked them if they thought these differences existed in the quality of hypertension care across race, ethnicity, which is in the darker bars, and then socioeconomic status in the lighter bars. And so as you can see here, almost 90% felt that there were racial ethnic differences in the US healthcare system. Over 40% still felt that there was differences in the quality of hypertension care across race within the University of Colorado and Denver Health. And then still over 30% of the responders also felt that there was racial and ethnic differences in the quality of hypertension care in patients they personally treat. And these were probably the ones that were at least willing to admit this. So when we see this disparity, it's not surprising that we see more hypertensive end-stage kidney disease in minorities, and especially again in Blacks and Hispanics. And remember, no matter what the cause of the underlying kidney disease is, if you have uncontrolled hypertension, it's going to cause more progression of the kidney disease. So this is a huge risk factor that we focus on. So Glomerulonephritis is also more common in minorities, and this is showing you the incidence of end-stage kidney disease by the cause being glomerulonephritis. And as you can see here, Blacks and Asians have a higher risk. And there's certain ones like focal segmental glomerulosclerosis that's been seen more in Blacks, IgA nephropathy. And so they started making people focusing more on genetics and potential variations in health outcomes that could be there. And the biggest player that we've seen emerge over the last several years is called ApoL1. So this is a circulating protein that can lyse trypanosomes. It's present in people of Western African descent, and it protects against African sleeping sickness. So this is where this came from. But they found that these genetic variants of ApoL1 are associated with kidney disease, especially in those diseases like FSGS, HIV-associated nephropathy, but also in non-diabetic ESRD. Now, you have to have two ApoL1 variants to be pathogenic, but these variants have been linked to as a primary cause of arteriolnephrosclerosis. And so many thought, well, this explains why Blacks have such a higher progression of their kidney disease. It's from having these genetics. And two of the largest studies, this one was published in the New England Journal of Medicine, looked at patients from the African American study in kidney disease and then the chronic renal insufficiency cohort, just large groups of CKD patients. And they genotyped everyone to see if they had these risk variants. And what you can see is up here, patients that had 0 copies or only 1 had a much better prognosis of their kidneys than the patients with 2 copies, meaning these patients progressed much more rapidly to end-stage kidney disease. And we can see that the risk also varied depending on your proteinuria status. So obviously the highest risk patients were those that had 2 variants and a lot of proteinuria, and they progressed very quickly to end-stage renal disease. So everyone felt this could be the reason. All these patients must have ApoL1. But when they looked, only 25% of patients had 2 ApoL1 risk alleles. So there's no way that this can explain all of the disparity in kidney disease. Additionally, this is specific to a part of Western Africa. So really, this is where their ancestry would be from. And now they're finding ApoL1, again, because race is social, not biological, where we have a lot of mixed races. And so they're finding this in people of Hispanic origin, et cetera. So it probably definitely plays a role, but it can't explain all of this disparity we see. So there's got to be environmental influences. And it's thought that there could be this second hit where it's an environmental influence, whether it's stress, toxins, et cetera, that could modify gene or receptor expression. And this could then worsen kidney disease. And so this brings me to socioeconomic factors. Now, no matter which disease you look at, morbidity and mortality rates are inversely related to SES. So as education, job status, and income increase, disease and death decrease. And if we look specifically at the development of end-stage kidney disease, what we see is very strong predictors of it are low income, poor education, excuse me, and residence in a low income area, and also poor access to healthcare. If we look just at chronic kidney disease in general, not even getting to dialysis, lower SES is associated with a 59% greater odds of developing CKD after you adjust for demographics, insurance status, and comorbidities such as diabetes and hypertension. This graph here is showing the age-adjusted rate of ESRD by race and ethnicity and SES in women. And what I want to show you here is low SES is on the left and high SES is on the right. And what you can see is no matter what the race or ethnicity is, there's a higher rate of ESRD in low SES compared to high SES. Yes, the rate is still much higher in Blacks, Native Americans, and Hispanics than it is in whites, regardless of low or high SES. But you can see that SES plays a huge role in end-stage kidney disease. And we know, unfortunately, that minorities are more likely to live in poverty. So this is the percentage of families living below poverty in 2019. And as you can see, Blacks and Hispanics have the highest rate of living below the poverty level. So not surprising then, minorities are more likely to be uninsured. And this is the uninsured rate for the non-elderly population, again, by race. You can see it's highest in the American Indians, Alaska Natives, followed by Hispanics, and then Blacks. So obviously SES becomes a big problem. And as I'll show you in a minute with these social determinants of what happens, but we need to look a little bit for a minute here on lifestyle factors in health and talk about culture and how much it forms attitudes to healthcare and why cultural competency is so critical for healthcare providers. So just to remind everybody, culture is defined as the set of shared attitudes, values, goals, and practices that characterize an institution, organization, or group. And it's really important to note that many minority groups have health-related beliefs that are influenced by their cultural history and religious backgrounds. And some of these beliefs may conflict with Western medicine. These beliefs could affect their lifestyle choices, their diet, their physical activity, for example. There could be significant language barriers with these. And so again, this is why the cultural competency of providers is critical. And as we talk about when we address these disparities, this is incredibly important. And it's important to point out that a lot of minorities have an underlying distrust of the medical profession. And a fair number may be convinced that doctors do not always have their best interests at heart. And if you guys have never read this book, I encourage you to do so. It's called Mama Might Be Better Off Dead: The Failure of Healthcare in Urban America. And this is a quote from that book. To a degree that confounds many whites, they worry that they could become unwitting subjects in dangerous human experiments. And this is, of course, referring to the Tuskegee syphilis study. You know, we're seeing some of the distrust now with the COVID-19 vaccines, where some minority groups are, more hesitant to get it. And we're seeing a big push in these communities of how important it is to get this. So again, something we need to really be cognizant of as healthcare providers. And this is because when we look at all of these things, we can see this socioeconomic deprivation and CKD and how these can come together. So if we look at residential segregation, these are poor housing, poor educational systems. These can be more exposure to things like lead and environmental toxins that lead to kidney disease, but also leads to lower health literacy, lower education. Of course, discrimination here in the middle, that's been shown to link to chronic stress, maladaptive health behaviors. Again, all these things have been linked to low birth weight, obesity, diabetes, hypertension, all these risk factors for chronic kidney disease and progression. And of course, if you're over here on the right and you're uninsured and underinsured, you don't have access to healthcare, you don't have means to start preventing CKD or at least the progression of it. And then when you get more advanced, you're not having access to transplant, as we'll talk about in a minute. And really going back to sort of this environmental influences, they really could be influences in these epigenetic changes. And so again, if we think about increased psychological stresses or physical and environmental stresses, they could be resulting in influencing expression of genes that are risk factors for CKD, or they're influencing downstream signaling things from oxidative stress and inflammation. And ultimately, all of these can lead to this accelerated decline in kidney function that we see. And the reason that these minority patients might have the more progression to end-stage kidney disease compared to whites. So as I just shown you, it's very complex in how these healthcare disparities arise. And unfortunately, once they're there, unfortunately, we still are seeing disparities in the treatment of kidney disease as well. I already showed you disparity earlier in blood pressure, but if we look at other disparities, white patients are significantly more likely than Black patients to achieve control of hemoglobin A1C, as well as can achieve control of their cholesterol. And primarily here, I'm showing you LDL. We know that there's an underuse of renin-angiotensin-aldosterone system inhibitors in minorities. So studies before 2001 showed no improvement in CKD or cardiovascular outcomes with RAS inhibition in African Americans. These studies were severely limited because they had very low numbers of enrolled African Americans. But despite this, this sort of became what everyone did. And so they were not using RAS inhibitors. And so it's this low rate of inhibitor use might contribute, again, to the progression of kidney disease. We know that RAS inhibitors are protective, especially in those patients with proteinuria. And we now know that they are effective and safe in African Americans. So this is from the ASK study, the African American study of kidney disease and hypertension of almost 1,100 African Americans. And those that were receiving an ACE inhibitor had a lower rate of kidney disease progression and a lower rate of death. But despite this, there's still beliefs, and when they've done the studies and they look again at the differences in hypertension care, there's still hesitancy sometimes to start an ACE inhibitor, ARB, as first line in African Americans who have proteinuria and kidney disease, because there's still some belief that they may not be as good as other blood pressure lowering medications. Again, minorities are less likely to receive any pre-dialysis nephrology care. So this is the percentage of patients who actually saw a nephrologist prior to starting dialysis. So you can see it's lowest in Blacks in the red and then Hispanics on the far right. Now, this becomes very important because if they're not seeing a nephrologist, they're not getting the same access to kidney transplantation, kidney disease education, preparing for dialysis, all those types of things. And so then it's not surprising when we start looking at the use of a fistula, which is what an AV fistula is, the primary mode of vascular access. When someone starts dialysis, we can see is lowest in Blacks and Hispanics. And again, we want everyone to use an AVF because this is a lower risk of infections and obviously lowers morbidity and mortality. But if you're not seeing a nephrologist, you're probably not going to have access to an AVF prior to dialysis. So now I'm going to talk about what we see in kidney transplantation. And minorities, unfortunately, are less likely to get placed on the kidney transplant waiting list. What I'm showing you here is the percentage that were registered on the transplant list within a year of starting on dialysis. Ideally, you would get placed on the kidney transplant list before you start dialysis. But this, we're looking at those once they got onto dialysis within a year. And you can see it's lowest for the American Indians, Alaska Natives, and Black patients compared to whites as to get on the waiting list. So then, not surprisingly, minorities are less likely to receive a kidney transplant. If you never get on the wait list, you can't get a transplant. So this is looking at all kidney transplant rates, both deceased and live donors from 2000 to 2018. You can see here it's lowest in Blacks, American Indians, Alaska Natives, and Hispanics. Now, what we've seen over the past few years is there's been no significant difference in the rates of deceased donor kidney transplantation between whites and Blacks. So this is a good thing. So we have whites here in the blue line. You can see the number of deceased donor transplants for whites has actually gone down over the years. And you can see here, this is Blacks in this lighter color, and then American Indians and Alaska Natives have increased. So this is good. This looks like this disparity might be improving. The problem is we've seen an increase in the disparity in the receipt of live donor kidney transplants. And this has gone up from 1995 to 2014. So here's whites from 1995 to 2014. And you can see they've had an increase in living donor kidney transplants. And here's Blacks at the bottom. They've actually had a decrease. Again, here's the deceased donor, no changes in mortality, but huge differences here between the whites and the Blacks. So one disparity got better, but here we have one that continues to increase. Well, why are we seeing this? And as I'm about to show you, unfortunately, there are disparities in every step of the kidney transplant process. It's a complex process. There's multiple things, but the first one is referral. And Blacks and Hispanics are less likely to be referred for a transplant evaluation. The study looked specifically at Blacks compared to whites, and they had a 44% lower odds of referral. Now, this isn't just due to one factor. There's patient factors, there's provider, and there's system level, which I'll show you. But patient factors, are these playing a role, or is this just lack of education? So studies have found that Blacks more often consider themselves in good health on dialysis. Remember, I showed you that mortality swap that happens, the reversal. They have more confidence in their prognosis on dialysis. Could this be because they're younger when they're starting dialysis? Patient knowledge is a huge issue. And one study found that only 21% of Blacks compared to 50% of whites knew basic transplant knowledge questions. So they don't even know the questions to ask. They don't even know benefits of transplant. How are they going to get there? And then something that happens with a lot of these communities and with minorities is sometimes they're less likely to discuss their situation, to discuss things with potential donors to actually get a living donor transplant. So a few years ago, we looked at our dialysis patients. So these were patients already on dialysis within the University of Colorado system and Denver Health. And so we surveyed them. And we wanted to find out what was discussion that they had with a provider talking about transplant, whether they were evaluated, and then whether they were listed. And what we can see here is here's our non-Hispanic Blacks and Hispanics compared to the whites. So the non-Hispanic Blacks and Hispanics reported less discussion with their provider about transplant. The Blacks had less evaluations and were less likely to be listed than the whites and the Hispanics, again, in our own system. We then asked them about their understanding of the transplant process, and Blacks and Hispanics reported less understanding. So here's Hispanic in the blue, non-Hispanic Black in the green, and then the darker green is the whites. And you can see here, the Hispanics and non-Hispanic Blacks were not sure how to proceed. They didn't understand the benefits of transplant. They didn't understand the transplant process. And you can see here, some of them even said dialysis isn't that bad, but you can see that none of the whites said that. And then down here, when we saw the ones who were not referred, we asked them why they weren't referred, and they weren't referred by their provider. And you can see here Blacks compared to the Hispanics and whites, and this was statistically significant. And so this was obviously very humbling for me when we found this in our own healthcare system. So this brings me to why would patients not be being referred for transplant? And this comes down to issues with providers. So there used to be this belief that African Americans were more likely to suffer long-term graft failure, so that they did not do as well if they got a transplant. So some studies had found that Blacks were 1.8 times more likely than whites to suffer this long-term failure. And this rate of failure was not due to, mismatching with the kidney or perfect matching or SES factors. However, the only SES factor they really focused on was disparities in insurance status. But newer immunosuppressive therapies have reduced graft failure in minorities. And so Blacks, I'm just showing you this here, have experienced greater improvements in survival. This is after deceased donor kidney transplants from 1990 to 2012. So here's 1990. This is 1 year graft loss, 3 year and 5 year. Not great when 50% are losing their graft. But in 2012, this significantly improved. And regardless, what we know is there's a survival advantage for transplant over staying on dialysis. So even if you have graft failure 5 years later, you still have that survival advantage in those 5 years compared to staying on dialysis. So this is something that we should be pushing for transplant in these patients. So there's also unfortunately been a lot of studies that have shown poor patient-provider communication. So studies have found that even when Blacks desire transplant, discussions are not occurring in about a third of cases. There's been qualitative studies that found that Blacks voicing their interest in transplant were still listed in the chart as not interested. And in pre-dialysis kidney disease, this leads to less preemptive transplant referrals. So ideally, you get on the transplant list when your GFR falls below 20, and you get a preemptive transplant, which means you get a transplant before you ever go on to dialysis. And another issue we've seen with providers is a large study found that only 41% of providers from over 250 dialysis centers felt knowledgeable to answer patient questions about transplant. So if our providers don't even understand all the benefits and everything to transplant, how can we expect our patients to? And in fact, when you look, patients are often unaware of their listing status. So this is not only from their provider, but this is now the transplant center and at more of the system level. So this was, I'm just showing you an example. It's a single center survey of dialysis patients. Over half of them had no idea of what their listing status was, whether they were on the list or not. 89% mistakenly thought they were listed. And we see this happen all the time. Some of the waitlisted patients that were temporarily inactive, let's say they had a hospitalization, they had, an MI or something, they didn't know they were inactive. And then when they looked at some of the demographics of these patients, 2/3 had completed high school and only 11% had a college education, and 83% were Black. So again, now we come back to this important piece of the socioeconomic status. And this, just like we saw with end-stage kidney disease, we see it with kidney transplant. So if you're an individual with a lower income, you are less likely to be found medically suitable for transplant, less likely to complete the pre-transplant workup, have lower graft survival, and you have higher rates of acute rejection. And this low income may actually accentuate racial disparities. So as neighborhood poverty increases, the likelihood of waitlisting for Blacks decreases compared to whites in each poverty category. Patient education is also incredibly important with transplant. College graduates are 3 times as likely to be waitlisted or receive a transplant compared to patients with less than high school education. Higher health literacy increases the odds of transplant. And then Black patients are less likely to be waitlisted or transplanted if they do have less than a high school education or just a high school graduate and some partial college. However, studies have found if you look at Blacks that have completed college compared to whites, there's no statistical difference in those that are waitlisted or transplanted. So again, showing the disparity comes with education, not necessarily race. Education level is also associated with kidney transplant outcomes. So again, more advanced education level, you have lower risk of graft failure and mortality. And again, this degree of disparities in these graft and recipient survival between Blacks and whites decreases with increasing level of education. So obviously, what I've talked about so far is showing you how complex these disparities are, and they exist in so many different factors. It's in risk factors, it's in access to care, it's in how these things are treated. So when we start looking about how can we eliminate these disparities, obviously we're going to have to use a multi approach. We can't just look at one thing. And in fact, I think we have to address disparities on many different levels. And so you have to address them on the patient provider level, the healthcare system level, as well as the community level. So if we look at the patient provider level, we have to do risk factor education with targeted interventions for high-risk individuals. And we have to have targeted interventions that are culturally tailored to patients, that make sense to patients. This is where this cultural competency of providers has to come there. We have to educate patients and providers on disparities as well as all these different risk factors. And in fact, this is now, this has been standard in our nephrology program here that we do have this as part of our curriculum, but unfortunately, this is not standard across the United States, even though ESRD is such a huge healthcare disparity. Effective communication, this has to be there as well. We have to be better job communicating with these patients and educating them. And if the providers aren't educated enough, as I showed you, only 41% felt comfortable talking about transplant with their patients. We have to do better at this in fellows education for our nephrology fellows, but then as well as when these fellows graduate and they're no longer practicing transplant. And again, we have to be aware of these cultural differences and primary values and these sociocultural and socioeconomic contributions. So now on the healthcare system side, obviously, if we had universal access to care, this would help significantly. That's beyond the scope of this talk that I can talk about today. But a patient-centered approach, again, with sensitivity to cultural diversity, the healthcare system should be focusing on cultural competence of their providers as well. Automated GFR reporting without the race correction. I'll talk about that more in a minute, but this is something, again, that can be quickly eliminated that could increase access to transplant. A team approach to maximize care. There's the chronic care model, and this is used for so many different diseases, and we don't do the best job with it with chronic kidney disease. And it's going to take all these different people working together to truly maximize care. And then we can't forget about the community level. So we have to identify community-specific needs, and different minority communities are going to be different. There has to be advocacy for social and health justice. And here we have Dr. Cervantes, who's done an amazing job with social and health justice for our Hispanic community here. Increasing organ donation, right? This is what we have to get out in these communities. And again, culturally tailor these interventions there to try to dispel these myths and things about organ donation, to try to increase this so these patients can do better, as well as awareness, seeking care, etc. So I'm going to talk a little bit more about things that we've done here at the University of Colorado and our renal division to try to address some of these. So what we've been working on is trying to eliminate eGFR reporting with the race correction. So just to remind everybody, eGFR means estimated glomerular filtration rate, and it's calculated from the amount of creatinine in the blood. In 2009, CKD Epi, and when you see your results in EPIC, whether you're at Denver Health or the university, you see it's used as CKD Epi. So that's what you're seeing on GFR. But in 2009, this established a race-based coefficient due to data that demonstrated Black individuals had GFR levels 16% higher than people of other races. And they attributed this finding that Black persons have higher muscle mass than white persons. And this was not measured at all in the study. So they just speculated that Blacks have higher muscle mass than whites. And again, they didn't find this for any other races. It's just Black versus other. And so what does this mean? What this means is you could have a 50-year-old male in your office, one's white, one's Black. They could be the exact same height, same weight, same muscle mass, same comorbidities. And the Black patient's GFR will be better than the white patient's. And as I'll show you, this can cause issues because that could lessen their ability for transplants, perhaps their referral to nephrology. In an ideal world, we should use the race-free cystatin C-based equation. This should become standard of care. It's not. We in the nephrology clinic will order a cystatin C quite often. Obviously, you can actually measure true GFR. It's nuclear medicine test. We can do it. It's more invasive, but the cystatin C-based equation would really be helpful. So if we think about what would happen if we eliminated this race correction, well, this could lead to earlier access to kidney transplantation. Remember, you can't be referred until your GFR is less than 20. This could be earlier access to specialty care. So it's almost universally accepted that patients will get referred to nephrology when their GFR is less than 30. So when they get into that stage 4 chronic kidney disease. Well, this would be great if we could get those patients, again, thinking about that example I gave you, if that man is sitting there, his GFR is 32, but the white man's GFR is 29, he might already be in nephrology. And what does this mean? Well, we do more specific kidney disease education. We prepare for dialysis. These patients are monitored more frequently once they get to stage 4 than they are to stage 3. And they could have increased access to things like medical nutrition therapy. So here's a study that just came out earlier this year, looking at the CKD Epi equation with and without race. And this is using data from that CRIC study we talked about earlier. And this was over 1,600 self-identified Black participants. So here's what happens at GFR less than 20 if we use the race correction, that CKD Epi. About 28.6% of these patients fell to a GFR less than 20. Look what happens if we take out the race correction. Now 36.4% fall to a GFR less than 20. Yes, we reclassified these patients to a more severe stage of kidney disease, but at the same time, they now have access to kidney transplant, whereas they didn't before. And if we look at the median time to achievement of a GFR less than 20, what we see here was 14 years if we use the race correction versus 12 without. So what that means is, again, they got there quicker, but if they had to wait 2 extra years, they couldn't get on the transplant list. And remember, ideally we do preemptive transplants. You get on the list before you start dialysis, and the average wait time is 3 to 5 years. So Denver Health has already eliminated this. We're working hard. We have a race correction task force within the DOM here that we're trying to get the university. Other places such as the Brigham, University of Washington, Seattle have all already made this change. So other things that have gone on here at UCH is the Hispanic Transplant Clinic. So this was established in 2018 by Dr. Monica Grafals. The entire team is Spanish speaking. So from the nephrologist to the transplant nurse coordinator to the social worker. So we performed a mixed method analysis looking at 406 Spanish speaking patients that were referred to UCH between 2015 and 2019. So we wanted to look at before the establishment of the Hispanic Transplant Clinic, and then compared it to after in 2018 and 19. And what we could see is during 2018-19, there was a percentage increase in the number of patients completing each step of the transplant process. 76% increase in referrals, 88% increase in evaluations, 155% patients actually made it to a committee review. So they were going through the steps, 50% increase in patients being waitlisted. Now, there was only a 5% increase in transplants, but again, this was just 2018-19, and the average wait time is 3 to 5 years. And when we did the qualitative part and we interviewed these patients from the previous years to then after the establishment of the Hispanic transplant clinic, the patients that had been through the Hispanic transplant clinic had a much better understanding of the transplant process. They had more education of the benefits of transplant, and they actually found the process more enjoyable than those patients from the earlier years. And then we also interviewed providers, and the providers also felt it was much easier to get their patients in. More patients were completing the process. And then we can obviously see that with the data. So this has been huge. They're talking about doing this Hispanic transplant clinic for other organs, such as lung, liver, heart, to try to, again, increase this. And this really is a model that we can use to look at other minority populations and perhaps how we can help get this disparity eliminated in our own healthcare system. So there are some other things that we're doing in the renal division. One of the things that we do is, at least in our dialysis units, we have like an all-in policy. So all of our dialysis patients are referred for transplant unless they have a current active malignancy and are getting chemotherapy or a very advanced dementia. So what this means is we do increased education by the providers, both the docs and our advanced practitioners who are there, and social workers. And so every month when we round, we discuss transplant with these patients. And we have definitely had patients who were never interested, who have now been interested and gone for evaluation. So it's working, but it does take a lot on our part. The other thing that we've done is have the education materials translated into the patient's language. So I was pretty shocked when I started as a medical director that they only had English and Spanish. So my dialysis unit is over here in inner city Aurora. I have Arabic, French, Korean, Marshallese, all these different languages, and we didn't have any patient education materials. So we had everything translated into their languages. And the nice part is we're a big, our dialysis units are owned by Fresenius. And so it's a national corporation. So now everyone across the country has access to these education materials. The other thing that we've done is we've partnered with the local NKF here. We do a lot of community engagement. We do this in both English, Dr. Grofals does it in Spanish, lots of education events for patients. We are involved with kidney disease and blood pressure screenings, these like free screenings for patients that the NKF helps sponsor with the 9 News Health Fair, for example. We obviously are working on ways in our clinic to have an epic alert pop up for those patients who aren't on dialysis, for when their GFR is less than 20, to make sure they get sent for transplant, et cetera. So we're doing things. There's obviously a lot more ways to go, but just to give you some examples of things that we are working on. So in conclusion, obviously there's a lot of healthcare disparities that are here in kidney disease. And as healthcare providers, we're accountable for the care that we provide. And I really believe that we need to view disparities in care as a quality of care problem that needs improvement. And we have the means to find and implement solutions to these disparities. So I'll just leave you with this last quote. When you have exhausted all possibilities, remember this: you haven't. Thank you. Be happy to take any questions.
Great. Thanks, Jessica. That was terrific. I want to get back to the race as a social construct concept, because I think that confuses a number of folks in the audience. There are genetic attributes that are associated with ancestry and associated with geographic place of origin. So tell us how this relates to how you balance this with race not being a biological, but being a social construct.
Yeah, I mean, it's a great question, and I think it definitely confuses a lot of people. I think the key takeaway is, yeah, I mean, ideally, they thought, oh, there's these 5 races and it's from these geographic locations. But when you actually look, there's a lot of mixing. And so it's not just distinguished geographic places. And if you could do everybody, genotype everyone, you could tell exactly where their ancestry was from. And the other issue that happens is the way race was defined changes over time. And that's happened as well. And so what they mean by that, it's social, is we start putting these people into specific buckets, not based on their ancestry. And so, for example, with kidney disease, we saw that with APOL1, like this is definitely, some people have these variants, this is genetic, but it's not just in Blacks. And it was saying that it was just in Blacks from this, but it's specifically Blacks that had ancestry. But how many patients are going to know exactly where their ancestry is several generations ago? And so I think when you talk to a lot of people, it's a different view of race. And again, like I said, it's not that race is imaginary, it's there, but it's more of this social way that we look at it, because it's the way we put people into certain buckets that we maybe shouldn't.
I think that's that's really true. I'll give a personal example. My son is adopted. He's African American, and he's probably the most tightly affiliated with Judaism of our three children. It turns out that when he had his genetics analyzed by 23andMe, he's a carrier of Tay-Sachs, and he's got all these Sephardic Jewish genes in him. It all of a sudden gave him a sense of belonging that he never had before because of being adopted, that enhanced his sense of who he was. And but it really illustrates the fact that we are a mix of
exactly.
a lot of ancestries, a lot of backgrounds, and it's important to recognize that, even though our appearances might belie that.
Correct.
But they do, and I want to sort of dig a little bit deeper with that concept. They do sometimes result in certain health risks, these genetic factors. So tell us how you weigh that.
Yeah, I mean, I think there's definitely could be genetic factors. I think you just can't look and say, just because this person looks Black, they have a genetic factor when they maybe don't, for example. So I think as we genotype more, and we're seeing that with APOL1, at least in the kidney world, is now they're finding it in Hispanics, and maybe that's explaining some of their progression. So I think we still need to think about genetics as being important, but not look at it just in the sense of race. And if something that is out of proportion, they're progressing quicker, family history, that there is something there. And we see that, like, a lot of these patients will have a first degree relative that had this, and then you can start looking that way. But again, trying to not just put it in the bucket of, well, they're Black, so they must have APOL1.
Okay, good. Now, how did these race corrected standards get established?
Yeah. So
what was the origin of them? Why did people begin to think about that?
It's kind of like anything with sort of race in medicine. They just started looking at Blacks versus whites in these studies. And when they were looking at using this equation to predict, they found that in that particular study, the Blacks had higher GFR than whites. And so all of a sudden it just became, that's what it is. This must be true. Looking at different populations, still a little bit different. So there must be a difference between Blacks and whites. And it just became what we used. And it's fascinating because it's really only been in the last year that this has become a big national movement. And it was started by medical students. It shows the power that they have to start asking these questions. Why are we using these race corrections? And then when you actually talk to somebody too, you say, well, what do you do if you have someone whose mother is Black and their father is white? And they're sitting there and they may self-identify as Black, but is that the right equation that you use? So then it started just, again, with these equations that we use in medicine, it just didn't really make sense, especially with this mixed ancestry. But that's just where it came from. And the people who created these are really standing by them, and it's become a big national movement. And the American Society of Nephrology and the National Kidney Foundation have put together a big task force that is supposed to help us answer, do we get rid of it altogether? What do we do? We are asking for it to just say one eGFR. And then if the patient's sitting in front of you and you want to order cystatin C, you want to order a true iothalamate clearance of their GFR to get a true measure of their GFR, you can do that. But this way we don't sort of discriminate against people based on just race.
So what's the biggest barrier that you think is preventing healthcare providers from acknowledging race as a social construct?
It's fascinating. And I don't know the answer to that, because you talk to some people and they look at it one way, and then you talk to others. our race correction task force has talked about doing that sort of study, just even within our own system here, to see what people's views are on this. I think it's just you have to look at it through a different lens. And it's not saying that everybody's racist. It's not saying that we're all racist people and this is how we're looking at it. But I think it's going back to say, with all, like you brought up, the mixed ancestry, how do you then say that they're truly distinguished by just their race? When you look at things and it's like 99.9%, it's exactly the same in every population. So, but yeah, I don't know, because like I said, I get different answers from different people.
Do you think it's generational at all?
I think there is that. I think it's much easier when I talk with the medical students, they see it right away, versus definitely older generations. I think, not that they don't see it, but I think it just maybe takes them a little bit longer of looking at stuff. People really like data. And when they're like, this is what I've been taught, this is what I was told, blacks and whites are different this way. And then you start saying, well, think about it like this. It's just, I think, a much different, you have to change your mindset.
So a really important concept that you brought up is access to a transplanted organ. Tell us about UNOS a little bit, and the potential that minority populations might have related to being eligible for organ transplant.
Yeah, so obviously the first step is they have to get there to get to UNOS, and they redid the allocation system, trying to make it more fair to help minorities, the way they allocate, at least for kidney transplant. So if you were younger, it used to be that you had to get right on the transplant list before you could accrue time. Now, if you've been on dialysis 3 years and you finally get on the transplant list, those 3 years of time actually are already accrued for you. So you move up on the list. So that's definitely helped the minorities. But yeah, so we've seen this with the minorities just not having as much access. And I think part of it is insurance. When they don't have insurance, they start dialysis, they're never seeing anybody before that. So all of a sudden they're just on dialysis, now have to go through this whole process, big life-changing things. We see that a lot of them don't have enough insurance, so they're underinsured in many different parts of the country to be able to get on a transplant list. They will look at their social situation. Perhaps they don't have stable housing. They don't have enough money in their bank account to think they can cover all of these things. And there's different centers across the country that you have to have a certain amount of money to do this, and it's not just insurance. So they've worked really hard here. Dr. Grafals has, with the Hispanic Transplant Clinic, getting these undocumented patients eligible for a form of insurance they can buy. It's at Denver Health called the Elevate Plan, and this has allowed them to actually get kidney transplants. So it's been amazing. So a big part of it is just insurance and then their access. I think the provider communication part is key, and that we see that they're just not having these conversations and not feeling comfortable. And I think, again, culturally tailoring these things. We do see that there's less living donations sometimes in different minority groups. And so getting out there, getting in the community, getting trust to actually get these people to start seeing this and seeking this care and organ donation as well.
Are there ways that we as providers, or as you as a provider of someone with chronic kidney disease, could approach some of those barriers that might be relevant to minority populations?
Yeah, I mean, I think the biggest thing is just having those conversations, number one, so that these patients get educated, so you can help increase their health literacy regarding transplant. So I think whether you're a PCP and you have your dialysis patient that you're seeing, and you're like, well, hey, have they talked to you about transplant? What's going on here? That would be better for you. Even just those conversations would be great. I think if anyone wants to get involved with our organizations that go out and do the screenings, do all this stuff, trying to talk about transplant, partnering with our local NKF. UCH has done a lot of these things too, where they'll do events here that the NKF and patients can come to. But I think removing some of these barriers is just a lot of education that we have to do, and we have to earn the trust of a lot of these populations.
One thing that you didn't mention, and is certainly along the pipeline of chronic kidney disease to dialysis to transplant, is getting patients ready for dialysis. But tell us a little bit more about disparities that might exist in terms of access to vascular surgeons that are providing access in a proactive way as opposed to a reactive way.
Absolutely. And so that starts with at first them having some pre-dialysis nephrology care. So that way we can start that, because we start access planning when the GFR is below 30 and usually below 25. And some people you have to do it quicker than others. And it's a real struggle depending on some patients' insurance status. We have a lot of luck at places like Denver Health University. We have a lot of our vascular surgeons who will put in access with people with Medicaid and things like that. But again, underinsured, it is harder to get some of those accesses in people. We're able to do it still for our undocumented, we're unable. So some of those patients that we see both in the hospital, I'm sure many here in the residents have seen them, as well as people we see in our clinic. If they're undocumented and they don't have insurance yet, we can't get them any access until they start dialysis. So that's a big barrier for us.
Well, Dr. Kendrick, this has been a really terrific discussion and great presentation, important topic and something we all need to think about, not only in terms of chronic kidney disease, but in terms of a lot of the chronic diseases that we take care of. So thanks very much. Really appreciate all the work that you put into this presentation.
Thank you. Appreciate the opportunity. Thanks.